Good morning, everybody. Thank you, Stan, and thank you to all the organizers of this meeting. I have a sea of pediatricians and GI docs, and as the lone neonatologist, hopefully I will help you with the very complicated babies that we often dump into your practices, and for that, oftentimes I feel sorry. And you have my apologies, because I'm probably the person who sends some of those most complicated patients to you. I have a disclosure. I have a grant for research through Prolacta Bioscience. And I want to talk today about just my objectives. I want to review the data on postnatal growth failure and its consequences, because this is very common in our preterm patients. Outline the goals of post-discharge nutrition for the preterm infant. Discuss key areas where research is lacking in neonatal nutrition. Discuss the unique properties and benefits of human milk, and explore the risks and benefits of informal milk sharing, which is really on the rise, and I'm sure you guys see in your communities. And then review some key practice considerations. So the goal of nutrition for our babies is they're designed to provide nutrients to approximate the rate of growth and composition of weight gain for a normal fetus of the same postmenstrual age. Sounds pretty simple. We want our preterm babies, by the time they go home, to be a term baby. Simple. Well, my favorite book growing up and when I could read French, which was very limited, is The Little Prince. And one of the guiding principles is you are responsible for your rose, which I tell the residents every day, and rien n'est simple. Nothing is simple. And that's absolutely true for our babies. These kids are very complex. Our preterm infants have increased macro and micronutrient requirements compared with the term baby. They're coming out partway through gestation. They should have had a zero net output of energy requirements, and they just are there to suck everything from mom and use all that energy to grow and develop. And all of a sudden now they're in the world, and despite our best efforts to put them in a neutral thermal environment and provide them with everything they need, they still have increased energy expenditures. And most of these micronutrients would have been acquired by them in the third trimester. Protein and energy deficits accrue very quickly in the initial postnatal period. I call it the nitrogen balance game when I teach the residents and also people in board review about what happens in the first days of life when you don't start TPN initially, when you're not aggressive about getting protein and other calories into these babies. And we're finally, I think, to the place where in neonatology we realize we have to start TPN on the first day of life with protein. We have to use higher protein preterm formulas and human milk fortifiers as early as the babies can tolerate it. And we also have focused on the initiation of early minimal enteral nutrition with breast milk or formulas in the first days of life, when most people in the days of past would have waited a week or 2 weeks to start some enteral nutrition. But despite all this, we really struggle to meet the goal of postnatal growth restriction and growth failure and on these babies coming out of the NICU. So postnatal growth failure and inadequate nutrition have been associated with poor long-term neurodevelopmental outcomes. And the reality is we care that our kids are growing, we care that they're a normal size, we care that they get to the normal height and weight of a regular teenage kid who can be a regular person, but we really care about how is their brain going to function, and are they going to be at a further deficit than other kids around them because their nutrition wasn't good in the days both in the hospital and in their initial postnatal course. The estimates of postnatal growth failure in the very low birth weight and extremely low birth weight infants range from 40 to 90%, depending on the series. And the smallest babies in that 500 to 750 gram range, the postnatal growth failure when we're discharging those babies is upwards of almost 90%, which is pretty staggering. The infants that are at most risk, obviously, are those that have complex morbidities such as BPD, NEC, and intraventricular hemorrhage. But it's really more than just calories for these kids. And I think that one of the most overlooked pieces of post-discharge nutrition, and actually even hospital nutrition, is that preterm and low birth weight infants are at increased risk for decreased bone mass, accretion, and metabolic bone disease. They're missing that whole third trimester of pregnancy when there's active transport of calcium and phosphorus into the baby. And they're unable to tolerate the full volume, full concentration feeds in the first days and weeks after birth. And there really is a limit to how much calcium and phosphorus we can put into TPN because of precipitation limits. And that's where protein becomes important, because you got to have enough protein in the TPN to get enough calcium and phosphorus. There are other things in the TPN such as aluminum, which contaminates some of our micronutrients, that also impair that absorption of the calcium and phosphorus by this small preterm baby. So I'm hopefully going to give you some guidance by the end about feeding the former preterm infant, and I think there are three kind of flavors. There's the exclusively breastfed preterm infant, there's the breastfed preterm infant who's supplemented with a post-discharge formula or fortification with a post-discharge formula powder, and the preterm infant receiving post-discharge or term formula. I will warn you all, I'm on the lactation task force for the state of Georgia and for CHOA, so I'm a huge breastfeeding proponent. So let them eat cake. The American Academy of Pediatrics policy statement is that human milk should be the sole source of nutrition for healthy term infants for the first 6 months of life, and breastfeeding should continue to 12 months of life, and human milk is the preferred source of nutrition for preterm infants. I think many people know that breast milk has a lot of significant benefits. It has a reduction in sepsis and mortality for the very low birth weight and extremely low birth weight infants. There's decreased rates of necrotizing enterocolitis. There's benefit for infants who have surgical disorders such as gastroschisis and intestinal failure. There is a reduction in BPD rates, which actually are proportionate to the increase in percentage of volume of mother's milk that they receive. And there's an increase in IQ points at 18-month neurodevelopmental follow-up. And that also is based on how much milk. The more milk you get, the more mother's milk especially that you get, the better the benefit. These benefits also continue into the post-discharge time with decreases in infections, RSV, ear infections. So there are a lot of benefits to human milk and breastfeeding. Unfortunately, human milk, as much as I hate to admit this, isn't really a perfect source of nutrition for that preterm infant. And this is just a chart that compares, and I'm not advocating any particular formula here, I'm just showing you a smattering of things that you encounter in your practice. And if you look in particular at the protein content of human milk, mature human milk has about 1 gram per 100 calories, gram per ounce. And you look at the post-discharge formulas are elevated about 2 grams. Term formulas are down at about 1.5 grams. So unfortunately, human milk does have some deficits, and the longer the mom lactates, the less protein and salt are in that milk. And the other deficit is really in calcium and phosphorus. And this is the place that those post-discharge formulas actually make some of the biggest bump. I think the caloric content and the protein content is certainly helpful for kids who are not growing as well, but the calcium and phosphorus is probably one of the most important reasons to consider keeping some babies on a post-discharge formula or making that in addition. So the questions really come in of whether the addition of human milk fortifiers, whether it's bovine or donor milk based during the NICU, really address the key disadvantage of human milk. Human milk is insufficient, as I said, to meet the nutritional requirements of preterm infants for protein, energy, calcium, and phosphorus, and important trace elements. So how do you supplement human milk to provide the extra nutrients if the infant is solely breastfeeding at discharge? What's the most appropriate caloric density of that supplement, or the amount of multinutrients that should be provided? How long should the supplementation be provided? What do you do for the infant who received donor milk in the NICU and the mother wishes to continue an all human milk diet but doesn't make enough milk to do that herself? And does post-discharge supplementation lead to improved overall growth and neurodevelopmental outcomes? So the data such that it's not great. There's not enough out there. Protein and mineral enriched post-discharge formulas, which are the bridge formulas, increase lean mass accretion, bone mineral content, and they provide a gain in head circumference and perhaps improve neurodevelopmental outcomes at 6 to 12 months corrected age when compared to those fed term formula. But we know that excessive catch-up growth has been associated with an increased risk of developing cardiometabolic disease. So we want these kids to catch up, but we don't want them to overshoot, and we don't want them to catch up too fast. Cochrane reviews of multiple studies, some of which are disparate, have shown inconsistent benefits and lack of long-term data. Does it really matter when the child is 4 and 6 whether we gave them term formula when they went home from the hospital or whether we gave them a bridge formula? And there's really no statistically significant difference in growth rates between preterm infants fed human milk fortified with multi-nutrient discharge formulas or compared with infants who are just breastfed when they went home. So, some general guidelines. The former preterm infant should be transitioned to the feedings that they will be on at home at least several days to a week before discharge to ensure that the feedings are well tolerated and that they're going to gain weight and take adequate volume of those feedings. That's our job. It doesn't always happen as perfectly as it should, but hopefully by the time we send them out to you, we've told you what to feed them. There should be communication from the neonatology team to the primary care provider before discharge. And the patient should be seen within 48 hours of discharge for a complete medical and nutritional assessment. And I can tell you, at least at Eggleston, we make that pediatrician appointment absolutely within 24 to 48 hours. And hopefully we fax you a discharge summary. The most important thing that I can tell you, though, is really you have to let growth be your guide. You need to obtain serial measurements of weight, length, head circumference, and they need to be plotted on validated growth charts to monitor the postnatal growth and identify potential growth or developmental issues. The key is you cannot use your standard growth curves for a preterm baby who was born at 24 weeks. You really need to use a growth curve that is adjusted for that preterm infant, and that is the Fenton or Olson growth charts, which can be used until 50 weeks postmenstrual age. After 50 weeks, you should plot them on the WHO growth charts, which can be used until 24 months corrected age. Don't forget that they get the credit for that 2 or 3 months that they weren't supposed to be here. That correction, the American Academy of Pediatrics feels should go on till the age of 3. And after the age of 3, they are where they are. And then they can be plotted on a regular growth curve and treated like a regular 3-year-old for expectations. The growth and nutritional assessments really should be obtained every 2 to 4 weeks in the early post-discharge period until the stable weight gain is established. For preterm infants who have concerns of growth failure or osteopenia at discharge, which is many of the babies that I sent home from Eggleston, you need to follow alkaline phosphatase, BUN, and perhaps a prealbumin and a calcium and a phosphate to really know whether the baby is, in addition to their growth chart, to know whether they really are nutritionally replete and on a good path, and what does their bone health look like. And remember that the American Academy of Pediatrics and Nutrition really recommends that these babies get about 150 to 200 mg per kg per day of calcium and about 75 to 140 mg per kg per day of phosphorus, which is provided somewhat in their formulas, but not often for the kids who come out at a deficit who can't eat an ad lib diet. They may not meet these requirements. And 200 to 400 IUs of vitamin D for all children, but especially for those very low birth weight infants. So what about this exclusively breastfed baby? You can let them exclusively breastfeed and follow growth and metabolic parameters. I think that's the ideal. Moms can pump and fortify every feed with a post-discharge formula, 22 or 24 or 27 calories, whatever the baby needs for growth, if that baby has signs of osteopenia and is not gaining well or comes out at the 3rd percentile when the baby was born at the 50th percentile. That baby needs some catch-up weight gain. Some moms will breastfeed and give 2 bottles a day of bridge formula or breast milk fortified with a post-discharge formula. And some moms who absolutely do not want any cow's formula, and if the baby has evidence of metabolic bone disease, you can add calcium and phosphorus to the breast milk when they don't need extra calories. Remember that term soy milk is not helpful as an additive. It's not going to give you anything additional at that point. Just let them breastfeed. It doesn't have any additional calcium or phosphorus over the other bridge formulas. And they do need 2 to 3 milligrams per kilogram per day of iron for the first 6 to 12 months. Many of these kids, again, are in an iron deficit when they come out. We draw blood frequently in the hospital and send it down to the lab, so it's not reclaimable iron for them. And there are very many complex patients that we send home. These patients have volume limitations. They cannot eat ad lib due to cardiac, pulmonary, or GI morbidities. The babies who are born less than 1,000 grams or less than 28 weeks are a particular risk. Those that come out with osteopenia, rickets, frank osteoporosis, or fractures. Babies with osteogenesis imperfecta, neurologic diseases, meningomyelocele. These are the kids in particular that you need to follow the calcium, the phos, the alk-phos. And the trigger levels really, if your alkaline phosphatase is above 400, your phos is less than 5.5, and your calcium is persistently low, that's a child who definitely needs to have some source of additional calcium and phosphorus, whether it's just those elements or whether it's in a post-discharge formula. That baby needs to have the addition of those elements and needs to be followed carefully. It also is an issue for some of our complex GI surgical babies who come out that are on elemental formulas, because for a preterm infant who's on an elemental formula, there really is insufficient calcium and phosphorus in those formulas, and they may need to be fortified with calcium carbonate and Fosnac. I'm just going to talk briefly about community human milk sharing, because I'm sure that many people have encountered moms, whether they tell you or not, they're sharing milk, they're cross-nursing, and wet nursing has been going on for thousands and thousands of years. But there's a resurgence in having your friend nurse your baby if you don't make enough milk, or eats on feets, Craigslist, buying milk on the internet. We feel like this is a somewhat dangerous practice, but it's going on wildly right now with social media. So the Academy on Breastfeeding Medicine has a policy statement that just came out last month on informal milk sharing. They recognize that informal milk sharing is increasingly common and has some potential health benefits for the term healthy infant, but really would like moms to adhere to some practices and guidelines to reduce the risk, which is medical screening of the donor. The mother should ask for the donor's medical history, especially the perinatal and prenatal history. Go over the prenatal labs, just as we would do, and ask her about her social practices. How much does she drink? Does she smoke? How many sexual partners does she have? And then safe milk handling practices. We can advise the moms who are going to listen or not listen to us that if they're not going to do that, that they might want to consider home pasteurization. And this article provides the recipe of basically how to cook the milk at home. It's almost like canning. Put it in a canning jar, cover the pan with milk, and you get it to a boil. Then take the milk out and let it cool. Put a cover on it and refrigerate it or freeze it. I think that we just want our parents to know that internet sharing of milk is very dangerous. But we agree that human milk does have benefits, and if they're going to do that, we advise them to learn to do a little cooking on the stovetop. So I think my take-home points are that suboptimal and varied nutritional practices regarding very low birth weight infants in the neonatal intensive care unit contribute to the continued growth failure and restriction in the post-discharge period. Human milk has many benefits and is recommended solely for term infants and a preferred source of enteral nutrition for preterms. Systematic reviews have really shown limited benefits in growth and neurodevelopmental outcomes with the use of the post-discharge or multi-nutrient fortification, except in certain patients. So it's important to have an individualized approach to the post-discharge nutrition for these very small infants and monitor them for growth failure, restriction, and metabolic bone disease. That's it.